Mr. Sugar did his FDS-RCS England and then FDS-RCS Edinburgh, FDS-RCPS Glasgow, MDHC Honorary Fellow CMU. He is Honorary Consultant in Cleft and Maxillofacial Surgery and Senior Lecturer at Swansea University Medical School based at Morriston Hospital, Swansea. Swansea is in Wales. He has main surgical interests in cleft, craniofacial deformity, and trauma. He was Clinical Director of the Wales Centre for Cleft Lip and Palate for 11 years. He has a major interest in 3D imaging and planning for facial reconstruction and remains chair of the Center and Applied Reconstructive Technologies in Surgery, which is known as CARTIS, C-A-R-T-I-S, a collaboration between Morriston Hospital and the design engineers at Cardiff Metallurgical University. He was a member of the Royal College of Surgeons Commission on Future of Surgery, which reported in 2019. He co-founded the International ADT Foundation with Prof. John Wolfert from Canada and Professor Rainer Smeltheisen from Germany. Adrian chaired NHS England's clinical research group for cleft lip and palate from its inception and the UK cleft development group for 6 years. He was president of the Craniofacial Society of Great Britain and Ireland and is now an honorary fellow for life. He was training program director for oral and maxillofacial surgery in Wales and chair of its specialty training committee. He chaired his health board's pediatric surgery, CTTE, and Morriston Hospital's medical staff. He is an elected trustee of the AO Foundation, internationally having sat on its academic council, the International Board of Craniomaxillofacial Surgery, chaired AO's International Research Fund, and all specialties and its research committee. Oh my God, it's so many things. He has more than 80 peer-reviewed publications in the literature, as well as 10 book chapters and 170 lectures by invitation. He was awarded the International Gelstrom Award for Excellence in Rehabilitation of the Head and Neck, and he was also given the highest prize that the British Association of Oral and Maxillofacial Surgeons gave away is Downs Prize. He was the recipient of Downs Prize also. So that is, in brief, Mr. Sugar. I request Mr. Sugar to start off with his lecture.
Thank you very much indeed for that very nice introduction, Professor Pradhan. It's always nice for me to be in Lucknow, even if only virtually. And I hope sometime again to be with you in reality when we can all start to do face-to-face once more. It's a strange situation we are all in, and we have to put up with it, I guess. I want to also thank Professor Malhotra for inviting me to give this lecture, and also my apologies for the problems that we had last week. I have discovered what the problem was, and I have corrected the problem. The only problem is I do not know how it happened. In order to make sure that it can't happen again, or if it happens again, Professor Malhotra now has a recording of my lecture. So if it does happen again, please don't despair, because she will be able to play the recording. The only other thing to say is that every time I give the lecture, the next time will be better. So today's will be better than the recording. So I promise you that. Just one brief break now. Thank you. It wasn't a comfort break. It was just that even in Wales, even in Swansea, occasionally we get the sun shining, and sometimes it creates a little bit of a glare. Okay, I'm going to bring up my lecture now. and hopefully we can, there we are. Fine, so what I'm going to do today is to provide for you an overview and an update on planning and surgery with distraction osteogenesis in the craniofacial skeleton. And of course, DO is the mechanical induction of new bone between bony surfaces that are gradually pulled apart. And of course, as they are pulled apart, so new bone is produced in the gap. And this is the father of distraction osteogenesis. This is Professor Gabriel Abramovich Ilizarov on the left. He looks, you know, it's a tradition in Europe, not in the UK, but in continental Europe, parts of it, and also Eastern Europe, for the chef of the department, the head of the department, to wear a chef's hat. I do not think you have to be able to cook to wear the hat. But so this is him in the where he was in his hospital base in Kurgan in Siberia, in what was then the Soviet Union. And he was a remarkable surgeon. What he found himself with a lot of patients coming back after the Second World War who had limb shortening injuries, especially of the lower limb. And allegedly, one patient had an external fixator for his difficult fracture, and he accidentally turned the key, which was supposed to be producing compression, and he turned it the wrong way to create distraction. And Ilizarov noted that new bone formed in the gap. So he described distraction, and he started to use this technique on his patients. And he had a lot of patients. And although distraction and DO was first described in 1905, its real father is Ilizarov. In the early days, the main problem was infection because there were no antibiotics. But after the war, there were some early antibiotics, especially penicillin, and it was possible to get decent results. And he treated thousands of patients using DO, and he published. It's interesting to note that initially his work was dismissed in the Soviet Union. And even in the West, he was ignored until 1980. And what happened then was that an Italian mountaineer by the name of Carlo Mauri, who was also a journalist, had a 10-year-old tibia fracture which had not united. It was a malunion and a non-union. And he treated Mr. Mauri, and he treated him successfully. The orthopedic surgeons in Italy had repeatedly operated on him, and it had failed. But it worked with distraction. And so he was invited by the Italian AO group to lecture in Italy, and that was the start of his recognition in the West. And now we have many countries that run Ilizarov courses, including the Royal College of Surgeons in England. Oh dear. That's better. My slides froze just for a moment. And we see bone and soft tissue deficiency is a major problem in certain situations. So for example, defects and deficiency in the craniofacial skeleton, congenital facial and cranial deformity, tumor defects in the head and neck and in the long bones, producing long bone defects, limb shortening problems, and even congenital limb defects like club foot have all been treated using distraction. And in the craniofacial area, we have instances of congenital patients with tissue excess, but the majority of such problems have tissue deficiency. And also the tissues, especially the bone and the soft tissues, are also often mostly the wrong shape. And so we constantly need to address this problem of how to deal with this tissue deficiency. I'm going to start talking about distraction in the mandible. And this is just some of the huge list of different types of devices that can be used for mandibular distraction. External and internal, combination of internal, external, and I will show you all of these. Then there are distractors that are partly fitted to the bone and partly to teeth, and even sometimes to dental implants. Some of the distractors are buried submucosally, and some are intraoral but extramucosal. There are even some that are removable and some that are resorbable. They can go in one direction, in two directions, or multiple directions. And I will try to show you examples of most of these. I'm sorry again, sometimes it sticks. So here are some of the distractors. So for example, top left here is the simplest distractor, which was the first one that I used in 1994. And I used it in a number of cases, some of which I will show you. And even though it's very, very simple and had the merit of being very cheap, one kit for one patient costs, I think in those days, $250 US. And it was devised by Molina in Mexico. And it was very effective. Then we started to get more sophisticated devices. So you can see below here, this is much better engineered, but of course, as a result of that, much more expensive, came from Germany, but it did a lot of different things, which I will show you. We then moved into some internal devices. This was one of the early ones, which I used. And then the combined devices. So this is mostly internal, but the port comes externally. It can go through the skin and into the neck. You can even have it going backwards. And when I first encountered this device, I thought it was a joke. I didn't realize that the joke was on me, because I use this device now extensively, mainly in the ramus of the mandible, but I've also, in India, when it was the only device available, I've used it also in the body of the mandible, and it worked very well. So I told you about the internal device, that one that I just showed you, the top one, was actually devised by Patrick Dinet, in Paris, and a good friend of mine, and he published his work in '96. So you can see that it was the 1990s that were key for the development of distraction in our field. What's the way of doing this? Well, the first thing, whatever the patient is that you have, is to decide if an intervention is needed. I can tell you that in the early days, especially in the United States, everybody was doing everything by distraction. There were many, many cases that were not really appropriate. So you really have to decide if an intervention using distraction is required. If it is required, then counseling and assessment of parents is the start, especially if you're treating children. After that, because without their support, it's not going to be possible, then you can go to counseling and assessment of the child and see what cooperation you can achieve. Sometimes you can obtain an OPT. Very often it's not possible in young children. And CT scan is usually possible either normally or with sedation, or in our early cases, as you'll see, sometimes we had to do general anesthesia in all planes and in 3D. So for example, when we first started doing distraction in the early 1990s, it took 30 minutes to do a full face CT scan in a child. And 30 minutes meant that child had to be still completely with no movement for 30 minutes. Now that thing can be done in the same way with better quality in less than 1 second. Photographs are needed, often dental models. We need to then be able to import the CT scan DICOM images into 3D planning software, appropriate software through which we can do 3D virtual planning and 3D printing of guides if necessary. So the principles of DO surgery are to put a distractor in place with the correct vector. In other words, the direction that you want the distractor to go in, to cut the bone and ensure the bone edges are separated. That's very important because it wasn't what we were told by people who had been the founders of this technique. I will come on to this. And they talked about corticotomies, where in actual fact, corticotomies don't work. Corticotomy means you just cut the cortex. It doesn't work. You have to do a full osteotomy. Then activate at surgery and then reset. And then a latency period of a few days, gradually lengthening at about 1 millimeter a day, and then a period of consolidation of at least 8 weeks before you can check that the bone has formed in the gap and remove the distractor. So what about distraction in the non-syndromic mandible? Well, first of all, I should tell you that I don't have a lot of experience with this because I think the majority of cases do not need distraction. A class 2 individual with a skeletal two-jaw relationship, which is mild, moderate as this is, can be treated very well with orthodontics and orthognathic surgery to advance the mandible. But sometimes the child, or even in this case the orthodontist, are very keen that this be done earlier, maybe because the child is being teased at school. So in this case, we were able to import not his lateral KEF, but his 3D CT lateral view through DICOM images into the planning software. And on that software, we could identify the bone that we wanted to move, which was the mandible. We could show where we want to make a cut in the bone, which is where previously second premolars have been removed. And we can place a distractor in what we hope is going to be the right vector, the right direction. And you see here, with this software, we're also able to do the distraction, to activate the distractor, and to bring the anterior part of the mandible forwards and create the gap. And we will discover whether distractor vector is correct when we see the position of the jaw of the mandible after the distraction. And if it isn't, we can just wind it back, change the position of the vector, and then try it again. And we did this in this case. You can see here on this OPT that the distractor is positioned, the cut has been made, but the distraction has not yet started. And here we have the distraction, actually it's been completed, but the distractors are still in position as we wait for the bone to consolidate. And down here you can see the bone is consolidated and the distractors have been removed. This kind of distractor can be awkward, especially for the child, because the ports of the distractor are intraoral. and they can traumatize the lips, etc. So getting them off early is valuable, but also being able to bend them so that they're not traumatizing the soft tissues is very helpful. And you can see here pre-operatively on the top and post-operatively on the bottom that we managed to correct his jaw relationships. What about more complicated cases where we want to not just lengthen the hypoplastic mandible by distraction, but also to do it in multiple vectors, multiple dimensions? These pictures are models from Cornelius Klein and Hans-Peter Howald. And Howald is now professor of maxillofacial surgery in Gießen, the University of Gießen in Germany. And they used to be in Frankfurt. And the idea here is that you can lengthen the ramus, as you see here, and also advance the mandible. But unfortunately, this isn't exactly what happens, because this is floating and can move. When you activate the horizontal part of the distraction, that can move back as well as this can move forwards. So you can produce improvements, but it's not necessarily what you would like to, what you would predict and what you would like to achieve. And so I only did this on 1 or 2 occasions, and this is one of their patients, and this is mine. And you can see the distractors in place in order to get vertical lengthening of the ramus and advancement of the mandible. Somehow or other, we managed to do it, but it wasn't predictable, and we therefore didn't use it very often. The surgical technique in these kind of cases is to do either an oral approach or a facial approach or a combined. It's very variable which is going to be the appropriate way. In very, very young children, sometimes it's better to go externally. A combined one is usually an oral approach with transbuccal instrumentation to drill holes and to insert pins or plates. Every case is different, and you have to consider what's going to be practical. Then doing the osteotomy, bicortical screws or pins in thin bone. By the way, in the distractor case that I just showed you, those were not those were monocortical screws in the distractor. Bunching of the skin to reduce external scarring. Consider swelling and consider pin and distractor care. And after the distractor insertion, as I said before, a short latency period, activation at about 1 millimeter a day, mostly at home, continue until sufficient lengthening has been achieved, and then a period of consolidation for the bone to form. I'm going to be showing you some cases of hemifacial microsomia, and therefore I wanted to show you this pictogram, which comes from a publication by Scott Bartlett from Philadelphia on hemifacial microsomia, and which I used in a chapter in a book I will introduce to you in a moment. And this shows what happens in the orbit, the mandible, soft tissues, mandible, hard tissues, the ear. Again, this is the facial nerve, this is the facial soft tissues, and this is whether there's a Tessier number 7 cleft or not. This complicated diagram does show the complexity of hemifacial microsomia. But I am wanting you to be focused on, for the moment, the bones, and especially these 2 classifications. 3 requires bone grafting because there is missing mandibular ramus. 1 probably doesn't need any or much surgery, and naught is essentially normal. And 2A and B are the ones that we might be considering for distraction osteogenesis. So they are to try and help you orientate yourself. And you will find that pictogram also in my chapter in this new book, which has only appeared in the last month or two, on advanced craniomaxillofacial surgery. If you, obviously, if you buy this book, it costs you money, but none of it comes to me, I guarantee you. But also you get a digital copy of the book as well as a hard copy of the book. And if you are a member of AOCMF, you get a very hefty discount if you buy this book. So that's my advertising finished. And this is one young lady who came to me when she was just 12 years of age, and she had a significant mandibular asymmetry, significant occlusal cant. Her left ear was slightly abnormal compared with the right ear, but not very seriously so. And this is what she looked like in terms of the CT scan, the 3D CT. Joe McCarthy published the first case of using distraction in hemifacial microsomia in 1994. And I did my first distraction case in hemifacial microsomia also in 1994. And this is the Molina distractor in position, and this is the distraction that has been achieved in this case to correct her short ramus. It's not so easy to see, but the ramus is quite small here, especially vertically, and it's a lot longer here after the distraction. And I mentioned Molina and his paper in 95, which was after I did my first case. And Molina had told me personally, and a lot of other people, that he only did corticotomies. And so my first case was a failure because the bone did not lengthen. And I had to take the patient back to the operating theater, complete the osteotomy, put new pins in, and then it worked quite well, as it did in that last case, this case that I just showed you. So this is this young lady before the distraction, and this is her afterwards. And you could see that we achieved quite a lot of, with a bit of orthodontic help also, some leveling of the occlusal plane, and also improvement in her symmetry. 1 year later, she came back and she looked like this. If you look at her chin, it's been maintained in more or less the right position. You look at the shape of the right side of her mandible, looks pretty good. The left side is also improved, but it's flatter. And she has a lateral contour defect on this side. Now, I don't know whether I would have treated this at that time, but she wanted it to be treated. I did not draw it to her attention. She drew it to my attention. So then we had to consider, well, what could we do? And so we thought that maybe we could see if there was anything we could do with distraction. So we took a model which had a sagittal split on it, and we inserted one of these distractors from the Normed company in Germany, and we put 2 pins in only the outer cortex of the condylar fragment here, but of course it had united by then, and 2 pins in the anterior to the osteotomy cuts bicortically for some rigidity. And then what we did was we loosened this screw here so that we could activate the distractor here by turning it. And what it does was it would draw the pins out through the distractor. You can see they're not visible here, but here they're coming out through the distractor, and this has brought the condylar fragment of the ramus laterally. Here you can see it in position before the distraction, and here she is, a very brave young lady. Her mother was a nurse, And I remember explaining to her at the time that not only had I never done this technique, but nobody had ever done this technique. And she should think very carefully before she let me do it, because even I wasn't 100% sure that it would work. But we did do it. And you can see this is before any surgery. This is after the first distraction, and this is after the lateral distraction. And I discovered her only last year. She's now teaching English in Tokyo, in Japan, and she sent me a photograph of herself, and she has maintained this symmetry, you'll be pleased to hear. So it works, and it works successfully. With pins, good pin wound care is essential. Some scars are inevitable with external devices, but if you bunch the skin, you maybe minimize them. And if you have lateral movements, the pins only come through the pinhole, so you don't have any scarring lateral to it. The exact direction of the movement is difficult to adjust during distraction, and correction in 3-dimension in one episode is hard to achieve. If you want to lengthen the ramus vertically, you can do that. If you wait for the bone to become solid, you can then advance the mandible with the second episode of distraction and wait for that to become solid. And if you want to lateralize the dimension as well, you can do that. Each 3 are separate movements and separate episodes of surgery is the way to go. And actually we should learn from our orthopedic colleagues, because with distraction, they often have to have multiple episodes to get the right result. This is another hemifacial microsomia case. This young lady was 4 years old when she came to see me, and she was a class 3 case because the top part of the ramus, the condyle, and the coronoid were missing. You can see this is her normal side. You can also see that we had to use a general anesthetic to get the CT scans. You can see the top part of the ramus is missing, and you can also see that the posterior aspect of the zygomatic arch is missing, including a missing glenoid fossa. And we did her surgery in stages. She first of all had a spinal fusion because she had severe scoliosis. She then had a rib graft to create zygomatic arch and fossa, and I'll show you the results of that. And she then had a costochondral graft, as you can see here, to reconstruct the ramus and the condyle. And you can also see that I have put here on this diagram a wedge of bone in the middle, because we want this rib to become very solid in the body of the mandible. If we have to do distraction later, and we did have to do with her, then we want to do it in this area of the stump of the mandible, not up here in the rib, so that it will work well. And this is the outcome after the distraction. There were 6 months between each of these 4 episodes, and this allowed time for the bone to become solid. And when she was 5.5 years of age, we lengthened the ramus with distraction. And you can see the technique that we used was to put the distractor on in what we thought would be the right vector, to then make a virtual guide on the computer screen with holes to put the distractor and also to a slot for the osteotomy cut. We then use a reciprocating saw to make the cut incomplete and to drill the holes for the distractor. One of these holes was also used to hold the guide in place. There's the outcome of that. We could then take with the distractor off, we can then complete the osteotomy, put the distractor in place with the port coming through the skin, and then activate the distractor as you can see here, okay? And this is the pre-op, this is post-op, And here you can see pre-op and post-op, and you can see the zygomatic arch has been fixed with a rib graft, which is taken well. One of the screws for the rib graft here, one there, and they didn't need to be removed, but we did have to remove the screws for the costochondral graft so that we could do the distraction, and that worked quite well. And you can see here before and after. Before and after as well. And this is her before, this is her after the distraction, and this is her after we also made a bone-anchored ear prosthesis for her. Another way of doing distraction in these hemifacial microsomia cases in the older age group, in the early teens. This young man had HFM on the right side. You can see his microtic right ear as well. But he also had a repaired cleft lip and palate, and his lip had already been repaired elsewhere, and his palate. And he had also had an alveolar bone graft. So the maxilla was in one place. And our orthodontist also considered that the maxilla, they could achieve a class 1 occlusion with orthodontics. But he needs this lower half of his face rotating like this. And the problem with doing this just on the mandible is that you probably will end up with a lateral open bite. And if he's 13 or 14 years of age, maybe that open bite will not close. So this technique was described originally by Monasterio in Mexico, and later also there was a publication by Caban in Boston, and we tried it on a 3D model. The reason I didn't do this virtually was it was the first time, and as with lateral distraction, I didn't know it would work, so I wanted to test it. And what I decided to do was we put the distractor on the right deformed mandible. That's the condylar fragment there. We did an incomplete LaFour-1. So I let the maxilla stay attached to the nasal septum. And what we found, and we put the teeth into occlusion and held them there so that he was in IMF. And then we lengthened the mandible and found that we could get good symmetry. But we also noticed that on the left side, the normal side, the LaFour-1 part of the maxilla wanted to go upwards. So we realized that what we had to do was when we did the osteotomy, we also had to cut a wedge of bone here to allow the maxilla to rotate upwards on this side and downwards on this side. And so here he is with his distractor in place. And here is the callus formed in the regenerate in the ramus of the mandible, the occlusion before distraction and after distraction. And this is him before and afterwards. And this is with a bone-anchored ear prosthesis in place. And you could see his occlusion as well. So it worked very well. A more complicated problem, and this is not a hemifacial microsomia, this is a complex condition that in fact is quite huge variation, and arthrogryposis multiplex congenita. If you look it up, you will find that it's many, many different manifestations. This young lady had a short ramus and a very large anterior open bite. The problem in these sort of cases is if you lengthen the ramus using distraction bilaterally, it does not close the open bite because it lengthens the ramus and it brings the mandible down. And so what we did with her was we did do distraction bilaterally, and then what we did was we took advantage of the bending of the distraction regenerate. In other words, we, during the consolidation phase, but early, so at only 3 or 4 weeks, We took the patient back to the operating theater. We took the distractor off, and we manually, without opening the wound again, bent the mandible upwards to close the open bite, and we put the patient in IMF for another 6 weeks. And it works. Another way of dealing with this problem, this is a very unusual case. It looks like maybe it's Treacher-Collins, but it isn't. It's actually bilateral hemifacial microsomia. And in this case, we use the technique of curvilinear distraction. In these, you have a curved distractor, which gives you lengthening of the ramus and anterior movement of the body of the mandible, and as a result, closure of an open bite. And actually, in this case, we overdid it deliberately. And it works by reverse planning. In other words, you plan where you want the mandible to be, and then you can calculate what the arc, what the curvature of the distractor should be to achieve this. And then the manufacturers will supply you with the distractor of the right dimensions, and you can go back and do the distraction. So that is another way of managing the same sort of problem. And I think finally in the mandible, unfortunately my videos aren't working, but you can even in certain selected cases treat a defect of the mandible using transport distraction. And so, for example, this is bifocal or trifocal. This is an anterior defect, and we're using trifocal distraction. This is the transport disc, this block of bone anteriorly here, and this block of bone anteriorly here, and you activate the distractor so that it slides around this arc until the two blocks hit each other in the middle, and they create distraction. And it works, and it's something to try when everything else has failed. So I have a few questions for you now. Am I right? Is it working okay,
yes,
Divya?
it's fine. Richa, can you put the poll questions now?
Yes.
Yes, I have launched the poll, ma'am. Okay. Is it visible?
So,
Not to me, but yes, let me ask.
I don't know, I got a pre-test in progress. I don't know what that means.
Can you all see the poll questions on your screen?
Okay, so yeah, so the first question is, when you insert a distractor, how long should you wait before starting distraction? So you've got three choices. A is 1 to 2 hours, B is about 5 to 7 days, and C is about 2 to 3 weeks. So you have a choice of A, B, or C.
I'll relaunch the poll.
Yes, please.
Divya, the questions I have on my screen are not these questions.
Yeah.
Ah, that's better. Thank you. Okay, can I go on to the next question?
Yes, please.
So the next question is, after the latency period, at what rate should you carry out distraction? So you have, again, three choices. A is 1 millimeter twice a day. B is 2 millimeters twice a day. And C is 1 millimeter a day. So three choices. 1 millimeter twice a day, 2 millimeters twice a day, or 1 millimeter a day. Okay, I think most people have voted now. And then we'll go to the third one, which is after you complete the distraction, how long should you normally wait before removal of the distractor or distractors? So A is at least 4 weeks, B is at least 8 weeks, and C is at least 6 months. So you've got at least 4 weeks, at least 8 weeks, or at least 6 months. So can we just look at the results, Divya?
I think people can't see the poll question. Can you relaunch them?
Ma'am, people have responded. I can see 35 people have voted.
Please look at your poll 3. Poll 3 is the poll on your polling list. You have to.
Yeah, it is appearing on the screen, and 36 people have already voted out of 82.
Okay.
So a lot of people have not voted. Should we come to back to that later, Divya?
Yes, please.
Okay. So we'll come back. You can put it on the screen later. Okay. So now let's go to the maxilla. Okay. In terms of maxillary advancement, for me, the only real question is cleft lip and palate, cleft palate in particular. And what are the questions then that we have for cleft maxillary advancement? So if we do it by distraction, would it make it easier to advance the maxilla and to achieve larger advancements? Fortunately, I'm not asking you these questions. I was asking me the questions. Does it make it safer to do it? Can bone grafts be avoided? Can internal fixation be avoided, plates, etc.? Can we avoid external frames? Is it likely to be more stable using distraction? Do we cause less harm to speech by doing distraction advancement? And finally, is there a difference in complications? So these were all the questions that I asked of myself. And I found out that there were external devices for using the maxilla. Polly and Figuera described the RED frame, RED meaning rigid external distraction. And there are many different varieties of the RED frame. And it's a bit like the concept of the Delaire face mask. And it's multiplanar. You can distract different parts of the facial bones. You can adjust it during distraction. There are negative psychosocial implications. You can get pin site infections and scars and nerve damage and maybe greater movements. But there are also distractors for doing this, which are internal. And this was the one that I decided to use because it had 2mm screws. It was quite rigid, and you could get between 10 and 25mm of advancement. So this is the way we did the planning. This is after orthodontic preparation, pre-surgical orthodontics, 3D CT scan, imported into software, identified the maxilla as being osteotomized, to do that in the software, and then advance the maxilla to the right position. You can also do it using freeform with a haptic. This is Peter Evans doing the same thing using a haptic. But we have to also try it on a model, especially the first time that we do it, and also because we have to make a guide. And we placed and trialed distractors on the model first to check that we had the right vector, to check the accuracy of the osteotomy cuts, to avoid teeth and nerves, and to ensure the plates and screws were accessible. And then we have to transfer that to surgery. So we know the vector's going to be right, but how do we put that to surgery? And this is on the 3D plan that we've now created a guide here. And the guide has holes in it for the distractor and also a slot for making the osteotomy in the right place. This is the guide 3D printed using sintered laser melting, and it's a cutting and a positioning guide. And here you can see the guide on the patient. And these holes are also, the same holes for holding the guide in position are also for advancing for putting the distractor on to advance. And here you can see it has been put in position, the distractors are in place, and you can see here the distractors in the bone, and you can see the cut in the bone. And remember what I said earlier about the mandible, that when you've put these distractors in place, you should activate them to make sure that the movement is in the right direction and is going to work. And when we did that, we found that we had one problem, and that was here. And that was that in an osteotomy, we just do the osteotomy, we down fracture the maxilla, we put the maxilla where we want it to be, and we plate it. But with distraction, it has to move. And you know, if you've got a road that has holes in it and bumps, it will be a bumpy ride. And this is exactly what happened here. It was a bumpy ride, and we thought it was in danger of damaging the distractor. And so what we did was we made the cut a little bit wider, only a little bit, so that when we activated the distractor, it was not a bumpy ride. And this is what it looks like when we've sutured the incision, and we've you still got the port, separate port here for the distractor. And this is preoperatively. This is after more than 2 centimeters of distraction, and this is after the distractor has been removed. This is 22 millimeters in this young man with a bilateral cleft lip and palate. And here you can see the maxilla preoperatively after orthodontic preparation. And here you can see the occlusion after the advancement. And when the distractor has been removed, we are then able to put some light elastics on just to maintain the position. And this is a second case, and we did 17, I think. And you can see a smaller advancement, but quite a significant improvement in this young lady. And by the way, it looks like she's had significant improvement of her nose, but this is without a rhinoplasty. This is just the result of the maxillary advancement. And so we did a study comparing doing cleft lefor 1 with an internal maxillary distractor and compared it with the previous osteotomy cohort. 9 of the distraction cases also were entered in the Eurocran distraction study. Female to male ratio was 6:9, and the mean age of surgery was 17.25, with quite a narrow age range of 16 to 19. And the study had 24 consecutive patients in the osteotomy group, lateral clefts. All of them had a good ABG done previously, modified incision, radical mobilization, advancement, plating, block bone grafting anteriorly, only anteriorly. In the distraction group, they were prospective, consecutive cases, 17. They also had lateral clefts. A standardized technique had also been bone grafted beforehand. Modified incision, but with very limited mobilization. CT scan, you've seen all the planning and advancement. And we had ethical approval and a research grant for doing that study. And we assessed hard soft tissue profile changes, stability, speech changes, and complications. Starting with the clinical results, of the 17 cases, 2 needed a mini plate at the time of distractor removal. That tells you that the bone was not solid. We didn't require or use a bone graft in any cases. We didn't create any fistulae, no holes. In all but one case, we achieved the desired maxillary position. One case was an anterior open bite where it didn't work. No parts of the maxilla were lost, and we used elastics to fine-tune and maintain the occlusion after distractor removal. What about the hard tissue and stability results? Well, in the osteotomy group, we had a mean advancement of 10 millimeters and a mean antero-posterior relapse at 1 year of 9%. In the distraction group, we had a mean advancement of 11.8 millimeters and a mean AP relapse at 1 year of 15%. There was no real difference statistically between the two groups of relapse. But the key point was there was no advantage for us in doing the distraction group in terms of stability, though there may have been some other advantages. So what about speech? Well, we had worse speech in 46% of the osteotomy groups and 33% of the distraction group. But when we looked more closely at the cases, we found that in the distraction group, there were many more patients who had had a previous pharyngoplasty. So actually there was no difference between the two groups. And that's borne out by other published work, which actually shows that using distraction to advance the maxilla doesn't give you better speech than doing it by conventional osteotomy. So finally, I want to talk about another group, and that is the craniofacial surgery group. And these are slides from my colleague Steve Dover in the Birmingham craniofacial unit. And just to start talking about monoblock. Well, this is frontofacial advancement, but not actually monoblock because it's in multiple segments. And the history of this is that Tessier described frontofacial advancement in 1971, but it was multiple segmental. And Fernando Ortiz Monasterio described monoblock advancement in 1976. So what are the indications for surgery? Well, to protect the eyes, to improve airway, remove or avoid tracheostomy and CPAP, improve dental facial relationships, cosmesis, and improve hearing, and protect the brain, especially protect the brain. And this is actually an example of the Chiari malformation of the brain stem and the possible benefit that would be received by monoblock advancement, and also improvement in raised intracranial pressure. Here you can see a young child with severe croissants, with airway issues, and also very severe proptosis, sorry, I should say exorbitism and prominence of the eyes with difficulty in the eyelids coming together, which has significant risk of damage to the long-term damage to the eyesight and damage to the eyes. So here we are, frontofacial advancement, frontal facial advance, and the monoblock. So that's the procedure that we're talking about. And the vector is determined by the orbital anatomy, and you can fix the distractor with bone plates in the piriform rim, in the glabella, and the frontal bone. If you only use one of those, then what happens is that the midface tends to rotate. And this is before, this is before, and this is after advancement. And the key points about frontofacial advancement are, it was developed by a monasterio, but it was associated with very high mortality and was then mostly abandoned in all craniofacial units. But when distraction appeared, monoblock was adapted for use with distraction. It was associated with low mortality in the right case and experience with good results, and also has been used very successfully for LeFor 2 and LeFor 3 advancements, especially in in craniofacial cases, but not for every case. And I just want to show you an example why not for every case. This was a patient of mine that I originally wanted to operate on when he was about 12, but he didn't want to have it done. He wanted to wait until he was an adult. Here he is at about 18 or 19 years of age. He has croissants, not severe exorbitism, but worse on the left than the right. The nose is very asymmetric, so that the nose is off to the left side of the face. So is the maxilla. The cheekbone is very flat here, and there's an anterior open bite. So when we looked at it, we thought this was going to be extremely difficult to do with distraction. And we were probably going to need to do at different levels as well. Just to show you here that this is before any mid-face surgery. This is the cheekbone and the right orbit, and this is the cheekbone and the left orbit. And you can see how much more of the orbital roof you can see because of the deficiency of the infraorbital rim. And we planned it in 3 phases and 3D planning. First, we did a LeFor 3 with a big rotation of the whole of the mid-face. You can see, especially in this view, the big difference with the advancement of the cheekbone and the whole of the maxillary mid-face complex. And also we brought it down because that's what the mid-face needed. Then we did a LeFor 1 to correct the anterior open bite and to level the occlusion. And then in the 3rd phase, we did bilateral sagittal splits to correct the mandibular asymmetry. Now, you might say, what mandibular asymmetry? Well, when you bring the, once you correct the position of the maxilla and the rest of the midface to the right, then all of a sudden the mandible is over to the left. So you have to move the mandible across to the right to meet up with everything else. And you can do this also with freeform. And we did it on a 3D model, not because we needed to do it, to plan it with a 3D model, but for 2 reasons. One, we thought it would be nice to be able to see where the bone grafts were going to be required, where the gaps were going to be, and plan for those. And secondly, because we could pre-bend the mini plates for the mid-face before surgery and have them ready and sterile to fix and save time at operation. And this is the outcome for this young man with his mid-face correction, orbital correction. His nose looks hugely better, but he could do with a little bit of smoothing down there, but he wouldn't let me go back to do that. He had some good reasons for not wanting to have further surgery. And you can see that basically his mandible, his maxilla, his mid-face are in a symmetrical position now. And of course, we've also got a correction in his open bite and his occlusion. And this is him before and after surgery, before and after surgery. So just to finalize a few aspects of this, what are the indications then? What have we learned about this, about the indications for doing distraction? Well, mostly it's suitable for congenital deficiency deformities like hemifacial microsomia and other abnormalities of the 1st and 2nd branchial arches. For example, Treacher-Collins, for example, Naegger syndrome. Maybe maxillary deficiencies in cleft lip and palate, but I have some reservations about that. Mid-face and cranial deficiencies in conditions like Crouzons and Aperts, especially in children. Severe mandibular deficiencies, sometimes in children when early intervention is indicated. Reconstruction of some mandibular and maxillary continuity defects occasionally, and maybe augmentation of the alveolus for dental implants. And that's just really a repetition of that, except also to add that one technique that was developed in Birmingham Craniofacial Unit and published by Martin Evans, who we used to work with us, is of the use of posterior cranial distraction in young babies when there was raised intracranial pressure. In the past, these would have been treated by the neurosurgeons by inserting a shunt, but in syndromic craniostenosis cases nowadays, very often an osteotomy of the posterior cranium with the insertion of a couple of distractors and actively moving the back of the head backwards helps to take pressure off the brain. And that's become quite a good thing to do in these cases. So we've learned that latency or the length of it may not be so important, but if you do wait too long, then the bones may have united again, that the speed is important. To overdo it when in the younger child, especially in asymmetry, because normal growth of the normal side may overgrow the correction of the abnormal side. Some people have problems with stability, especially in mandibular and maxillary cases, and you can overcome that by removal of distractors and inserting plates to stabilize the new position of the maxilla. And in the United States, in some of the craniofacial units, some units are using extremely long periods of consolidation, up to 6 months. And that seems also to be effective. Avoid multi-vector simultaneous distraction. And it's a great tool, is distraction, but it's not the only tool in our kit. Thank you very much indeed.
Thank you, Mr. Sugar. It's always a pleasure to listen to you and learn from you. And you have shown an excellent series of your cases. Thank you for adopting our department and being a mentor, guiding us through our journey in maxillofacial surgery. So what I saw you doing when I visited your center in 2005, since then we have been trying at our center to have that system developed of doing 3D planning and digital planning and achieving that type of accuracy. So initially we did get some help from the software companies and could plan our cases, but finally, maybe after 15 years, we feel proud that yes, we do have the entire system now, and we are doing that with the system we got trained. So thank you for being the torch bearer for us. So
no, it's a pleasure, and it's good to know that you're doing it, and I hope you're getting good results as well.
yes.
Would you like me to answer any questions, Professor Malhotra?
Yeah, that's what I'm looking at. The two chat collaborators, Dr. Jitendra and Dr. Gaurav. Do you have any questions from the audience? But till then, I would like to ask you, Mr. Sugar, usually the result of an extraoral is that there is a scarring, and with intraoral distractor use, the distractor is hidden and the patient is more comfortable with it. But what we feel as in our experience, that removal of an intraoral distractor is such a pain. There's so much of fibrosis all around. It takes so much of time and effort that we prefer, most often we prefer to do an extraoral distractor rather than an intraoral. What's your experience, and what do you suggest?
Well, first of all, I think you are right that it can be difficult with the scar tissue to remove a distractor that's intraoral. We would find, for example, the ones for the maxilla, for the cleft cases were very difficult to remove. And of course, you have three problems here. If it's difficult to remove because of the scar tissue, if you're not very careful, you could destabilize the distraction by trying to remove the distractor. So it's not easy to do. Secondly, then of course you can wait for maybe 6 months. Now that's, it's not the end of the world if it's really the only way to do it. But you know, then you will have another problem. And you know what that will be? Then you won't have fibrous tissue, you'll have bone. And sometimes that bone will grow over the distractor and over the screws. Then it can be very difficult to remove the distractor. You may have to get a drill out to drill bone over the distractor in order to be able to get it out. So I completely agree that it's not without its problems. On the other hand, if you are doing lengthening, lateral distraction is different, because apart from anything else, nobody has ever described a distractor that can do lateral distraction intraorally. I think it might be possible, but it's extremely challenging technically to devise such a distractor. So, and you don't really get much scarring when you do it externally. So that's great. But in some of the other cases, you do get significant distraction. Sorry, significant scarring, and it's challenging. Yeah. But I don't blame you for choosing that, you know.
Yeah, and the suggestion from you that you bunch up the skin so that the skin is not stretched, then the impact scar would be lesser. So that is a tip for the youngsters to just know.
Yep, absolutely.
There's a question from Dr. Hari Krishnan. Is distraction better with 0.5 millimeter twice or 1 millimeter once a day?
We didn't talk about the questions, did we? Well, just let me give you the answers to the questions. And but obviously the latency period, most people go for something like a few days, so 5 to 7 days. Activation is usually about 1 millimeter a day. Yes, to answer your question, you can do it 0.5 millimeter twice a day. I never found the need to do this. One of the reasons for that is that in young kids, sometimes they get quite a bit of pain when you are doing the distraction, when you're activating it, and of course with the parents at home as well. And so what we did was, first of all, we in those kids that were going to have pain or were having pain, we would sometimes give them an analgesic, just an oral tablet, about half an hour to an hour before we activated it. And secondly, if you only have to do it once a day, I think it's better for the kids than having to do it twice a day. But from a technical point of view, it doesn't really make any difference. But if you do more than 1 millimeter a day, you are likely to have problems where you don't get solid bone in the gap. And what was the third question? Consolidation. Yes. Generally speaking, you have to, at the end of distraction, when you stop, you have to wait until there's bone in the gap. So in theory, it doesn't matter how long that is. You need to have bone in the gap before you take the distractor off. I only had one case where I took a distractor off too soon, and I ended up having to go back and reoperate on that patient. So it is important to see that there's bone there. Generally speaking, that requires at least 8 weeks to get some solid bone there. But I've already said that some people are waiting even longer than that. I hope that answers the question.
And similarly, what you showed your cases with intraoral maxillary distractors. So any preference over the red frame? The extraoral distractor?
Yes, red frame is quite disturbing for the kids. Yeah, if we can do it without a red frame, it's an advantage. Remember how long it has to be there. That red frame has to be there for at least 3 months. Long time
Yes.
for the kids.
Do you see any problem with the intraoral maxillary distractors in place? Because there is so much of the distractor arm is also inside the oral cavity, and it may interfere with the cheek movements, and there may be
Well,
around the cheek because of that.
we didn't really. I think that the very first case I did was actually the daughter of an endocrinologist, a colleague of mine, and inevitably there was some difficulty in activation, but we overcame, especially in finding the port intraorally. More important with that distractor is that when we did come to take them off, once we realized that sometimes the scar tissue caused a lot of problems, sometimes we would cut the distractor to bits. In other words, when we were taking it off, if it proved difficult, so we would cut the plates. The only disadvantage of that is you get a lot of metal powder. So you have to be quite careful in suction and getting it off. But you can make it a bit easier to have to remove the distractor if you take it in pieces.
Many times, many authors have reported that during the consolidation phase or during the distraction phase, they use some BMPs or some other agents to to fasten the process. So have you been using any such procedure in your practice?
Well, no, I haven't, but we've always hoped that something would come along like BMP, which would help to reduce the consolidation period. But it doesn't seem to, there doesn't seem to be very much in the literature about it. Have you seen anything that's been positive? And the other thing is, do you know how expensive BMP is?
Yes, 1 lakh per patient.
It's very,
one dose.
very, very expensive. Yes, so there are some problems with that. Yeah.
So somebody asked role of platelet lysate in bone consolidation and distraction. So I don't think we use any platelet lysate in bone consolidation and distraction.
Sorry, is that a question?
Yes, your experience on role of platelet lysate in bone consolidation in distraction.
I don't really have any experience. I think I would have been tempted, if I had had it available at the time, I would have been tempted to try PRP, platelet-rich plasma. And I have to say that I always hoped that platelet-rich plasma was going to be a very big thing, because the advantage is you have to buy one of those centrifuges. They're not very expensive, and they go for a long time. And then you take the plasma from the patient. You don't have, it's not a big expense. And I always thought that would be great if it worked like that, if it worked. But there really hasn't been much positive that's come out of it. So I have to say, I don't know. I wish there was something that would make the consolidation period shorter, that would make the bone, the new bone, form faster. But I don't think we are yet at a position where we know there's something that we can use that is also affordable.
You already expressed in your talk that you had compared the osteotomies over distraction. But there is a question, your experience on osteotomies over distraction, especially in advancement. What would be your choice of treatment for large advancements, and to how much would you advance with osteotomy and how much?
Well, I think with the, with the distractor, that the internal distractor that we were using, we could only go up to 25 millimeters. And that's mostly the case with maxillary distractors. And I know that my friend and colleague, also retired now, Professor Hemprich from Leipzig, he had a lot of very, very, very severe cleft cases needing needing advancement of more than 3 centimeters, 3 to 4 centimeters. And he did these by external distraction. And I think that would be sensible to do that for that sort of advancement. Hopefully, we won't need to do that. I mean, in our clinical practice, say that again?
How much of
say that again,
advancement have you made with your orthognathic surgical procedures? How much are you comfortable doing with your orthognathic procedures?
Well, I know that I have done advancements of more than 2.5 centimeters. The problems then is that, of course, it can be difficult. You have to really mobilize the maxilla very well. But there's more to it than that. If you have to do an advancement of that amount, then the maxilla is always very small to start with. When you advance the maxilla at Lefort-1 level in a small maxilla to maybe 3 centimeters, you almost have no contact anymore of the bone. And I managed to get away with that in 1 or 2 cases with bone grafting and successfully, but I think it's really, really challenging, advancements of that amount. And it's maybe even I would think about, should we do maybe 2 centimeters on the maxilla and maybe 1 centimeter moving back the mandible. I think each case has to be considered separately.
Yes. Thank you so much. There are several other questions which I think they can continue a lot longer. What do you say? Should I mail it them to you for your reply?
Gosh, I have to tell you that I hadn't even looked at the chat, but now I do. I can see that there's a lot of comments, etc.
Yes.
Would you mind if could you leave the line open so I can answer some of these questions? Or can I do it now?
Yes, yes. Yes, please.
Let me do it now then.
So, yes.
I hope, sorry, is that okay?
Yes, that's fine.
Yeah, okay. I think to Hari Krishnan, I think I answered that question about the speed of distraction. Is it better twice a day? I don't think it's better, but you can do it both ways. Is the stable treatment lifelong? I don't know whose life, my life or the patient's life. But I do think that there's good evidence that the stability, you get just as good stability with good distraction as you do with anything else. If you're treating a child during growth, then growth can often overtake the correction, and you may have, I always tell the parents of young children that if I do distraction on them when they're young children, I may have to go back when they are teenagers and do it again. And they have always accepted that. And there are cases where I've gone back and done it again. Hari Krishnan asks another question on newborns with Pierre Robin. I could talk to you for the next hour or two about Pierre Robin. I do not think in the overwhelming majority of cases that distraction is the right thing to do for Pierre Robin sequence. In Pierre Robin, the most important thing is is the positioning of the patient, the use of I will, if you like, I can send you a protocol. If Mr. Hari Krishnan would like, I'll send him a protocol, our protocol for Pierre Robin sequence. I can do that by email if he sends me my. Let me just put up my email address so that. If I there we are. Can you see that now? I have two email addresses there. There's my hospital one and there's my private one there. And if you'd like to send me your email address, I'll send you our protocol. Okay. I look at the rest of the chatting now. With the Le4-3 distraction from Rolson, I would say that if I could have done the case, if I can do the case with Le4-3 distraction, I would prefer to do that. In that case that I showed you, I think it was very difficult. With children, I would prefer to do by Le4-3 by distraction. In adults, the problem is that usually if you do a Le4-3 in an adult, you almost always have to do a simultaneous Le4-1 as well. So that would be a different situation. You also said about asymmetrical movements. I've already said that I think that with asymmetrical movements, it's very challenging to do it by distraction. For mandibular asymmetry, BSSO or vertical ramus. Vertical ramus osteotomy is not very often. I did about 40 cases consecutively in non-syndromic cases, and it's not very, it's not that stable a procedure. And I don't think the choice in mandibular asymmetry is between BSSO and vertical ramus. The choice is between BSSO and inverted L osteotomy with bone grafting. If the ramus needs to be lengthened vertically and advanced, then it's better to do an inverted L osteotomy with mini plate fixation of the ramus and bone grafting in the gaps. And if you don't have to lengthen the ramus vertically, then a sagittal split is probably better. So I hope that answers Jitendra Arora's question. And I see Hari Krishnan's quoted his own paper, which is fine, very good. Thank you very much. And I'm sure we'll be very happy to look at that classification of yours. Is there anybody I missed out? Thank you for your comments, Professor Dubey. Okay, I hope that answered all of the questions.
Thank you, sir. We're looking for a ma'am. I think there's some.
Have you've lost Dr. Baratra, have you?
Not really. But
Don't worry. I think, and if there are any more questions, I will answer them. And if not, maybe we should just close the session, huh?
I think these questions are almost complete. So I would request Pradhan sir, so we'll for an official felicitation. So could you say a few words, sir? Pradhan sir. So you're muted, sir.
Yes, Mino, you're muted. You have to open your microphone.
Okay, I'll do it. No, I'm
That's
not
it.
muted.
That's worked.
Even I could understand everything on from the lecture. So I think others who are presently involved in this sort of work would have benefited a lot. And like always, Mr. Sugar is a pleasure to listen to. He is so well tuned in talking and so well used to talk to Indians, especially in Lucknow, that he knows what to talk. Thank you very much, Adrian. It was a wonderful talk given by you, like always. Thank you.
Thank you very much for your nice comments. It was a pleasure to be able to be with you today.
So I would request now to Pradhan sir to give an e-certificate to Dr. Sugar. So I'll share my screen.
How do you do it?
I guess you need to send it by email. Huh? Oh my gosh. So how do I acquire it? I don't know.
So we'll send you by an email also.
Thank you very much.
Thank you, sir.
And very kind of you. Thank you so much.
Thank you so much. So we would also have a small valedictory function. So we have our chairpersons and moderators here. So one by one, we will felicitate them with these e-certificates. So first of all, I would request our chairperson for the day, Professor R. Pradhan sir. So I request Dr. Sugar to present it to Dr. Pradhan on an e-platform.
Of course, Professor Pradhan, I hope you will accept this certificate of appreciation, and thank you for co-chairing this session.
Thank you very much, Adrian. It is like give and take.
This time you have to take.
So we also have receptions for our other chairpersons for different other sessions. So we have Professor Chandra in the session. If he's there, then
do you want me to do it?
I think if he's there, we'll be able to see him. But one by one, I'll just move over the certificates, and if he's present, we'll on an online thing, we'll like request them on our behalf.
Okay. Can I just say, very nice to that you are here, Professor Shadab Mohammed, and I'm very pleased that you would take this certificate.
Sure, perfect. So next we have Professor Gaurav Singh sir, who has chaired one of the sessions of our 4th week.
Very good.
And we have Professor R.K. Singh sir. I think sir was here.
Good. To Professor Singh as well.
Yes, sir. Thank you.
R.K. Singh.
And we have Professor S.S. Ahmed, sir.
To Professor Ahmad, thank you.
Professor U.S. Pal, sir.
Thank you, Professor Paul.
Professor K.N. Dubey, sir.
Thank you, Professor Dubey. Good to see you again. I did see you.
He was there today. He's there. Professor Naresh Sharma, sir.
To Professor Naresh Sharma as well.
Okay, now we have session moderators also. So Dr. Madan Mishra, who have been behind, like all these people have been behind individual sessions and they've worked hard over it. Dr. Madan Mishra as session moderator. Then we have Dr. Divya Mehrotra ma'am. She was moderating today. Somehow we were not able to connect with her. Dr. Shuchi Tripathi as session moderator. We have Professor Hemant Gupta, sir, as session moderator. We thank you, sir. Then we have Professor G.S. Hashmi, sir, as session moderator. So if any one of you are present, please, you can switch on your video so that everybody can see and that how.
Yeah, thank you, Richa. Thank you, Richa, for your giving me certificate. But first of all, I'd like to thank our teacher, Professor Pradhan sir is here. After a long gap, I've seen our teacher. So, Professor Sugar sir, once again, good evening to you also, sir.
Good evening.
I've been trained under you in Lucknow in so many occasions. So it's nice to see you after a long gap. Thank you, Richa.
Thank you, sir. It's our pleasure, sir.
Yeah.
Then we have chat coordinators, Dr. Atish Kundu. Can we have Dr. Atish? Okay. We move on. Dr. Akhilesh Singh as chat coordinator again. So these people have been coordinating chat on chat box on Zoom as well as on the YouTube link. Dr. Arunesh Tiwari as chat coordinator. Gaurav Singh sir is here. Thank you, sir. We have Dr. Siddharth Chandel as chat coordinator. Dr. Gaurav Mahesh Gupta as chat coordinator. So we still have, just a second. Yeah, Dr. Ami Agarwal as chat coordinator. Dr. Chandresh Jaiswara. That will do. So whatever certificates are there, we will send you individually by emails also, all the session moderators, all the chat coordinators, and all the people who have worked hard to make this event successful. And all the guest speakers who have been we already have felicitated our guest speakers in the individual sessions, and we'll mail the certificates individually to them on their emails also. So somehow we are not able to connect to ma'am. I'm trying to call her also, but we are not able to connect, some internet issues, some network problems. So again, Dr. Sugar, I sincerely thank you on behalf of Dr. Divya Mehrotra ma'am for being a part of this event and for sharing your knowledge on this platform. Thank you very much, sir.
It's a pleasure, and I'm glad that you had a good series of lectures, and I hope they all went very well. Thank you very much for having me.
So I'll request all participants to submit the Google form again. So that would be your eligibility for the certificate of participation also. So please submit. I'm again typing the link on the chat box. So we still have got just a 25 to 30 responses. So please request everyone to fill the feedback form again.
Richa ma'am?
Yeah. Yes, madam. Yes.
Before we close this session, I will request our secretary and president of UP's state MSI to address this session.
Sure. Please.
Yeah, please. I would call upon Dr. Ghulam Sarwar Hashmi, secretary of our UPMSI, to say a few words.
Thanks, Madan. Respected teachers and Professor Adrian Sugar sir, my seniors and my dear students. Good evening to all of you. First of all, I'd like to congratulate for attending such a wonderful program. And it was running since last 2nd of November onward. And there were the series of the 4-5 lectures. And it was a pleasure for us to have such kind of excellent lectures and the excellent speaker we had. So with these words, since I have given a duty to address the UPMSI members in particular, so I would like to request to all the head of the institution of the UP's dental colleges, especially in the Department of Oral and Maxillofacial Surgery, to call all your first JR1, first year PG students to go for the national membership of the Association of the Oral and Maxillofacial Surgery, so that there are, since we have lots of benefits from the national membership, although the academic, the physical academic activities are not in a good mood, but there are lots of virtual meetings are going on in terms of the academic upliftment of the oral and maxillofacial surgery. So once again, I would like to request all the chairpersons of the Department of Oral Maxillofacial Surgery in the UP's dental colleges to call all the freshers, I think the JR1s in the department, for the making of the annual membership of AOMSI. Thank you so much. Thank you, Richa.
Thank you, sir.
Thank you so much, boss. Now I would call upon our president, respected Professor Dr. Gaurav Singh, Principal and Head of Department, Maxillofacial Surgery at Sardar Patel PG Institute of Dental and Medical Sciences. Sir, please, if you can say a few words to us.
So you are muted. So Gaurav, sir, you're muted.
Good evening, everyone. As President UPMSI, I thank you all. My sincere thanks to Pradhan sir and Sadap sir for their guidance. Special thanks to Divya Malhotra ma'am for organizing such an event. In future also, we will keep on organizing such an event for benefit of the students, my dear colleagues. And last but not the least, my thanks to all the speakers, moderators, and participants to make this event a grand success. And thank you so much, Richa, for a very nice coordination.
Thank you, sir.
Thank
So
you.
we will also share the results of the poll so that sir may know what were the what people responded. So is it visible? The poll results, are they visible on the screen? So this was like, so the person shows the percentage of participants who responded in each of the items of the questions. We did it just in the middle of the session. So I stopped sharing the results. I think that's fine.
Okay, Richa, can we leave now?
Yeah, sure, sir. So thank you.
Thank you very much. Thank you for having me.
Thank you, and I will be leaving now as well. Thank you very much.
Thank you. Thank you so much. Thank you. Thank you, everyone.
Thank you, everyone.
Thank you, sir.
Vignesh? Vignesh? Sanjay? Dr. Sanjay Singh?